Pictures going. So we're not going to spend just a tremendous amount of time in chapter 9, but it's worth discussing. Go through dose limits or anything like that, but we'll talk about interactions with matter, differential absorption, types of contrast. So of the 5 interactions with matter, we're really only interested in 3, and of those 3, primarily, 2. So transmission is not really an interaction, but it's worth mentioning. Transmission would be where we get an X-ray photon that goes all the way through the patient, doesn't touch anything, so it's not scattered, it's not absorbed, doesn't lose any energy, it doesn't touch anything, it just goes straight to the patient, doesn't contribute to the patient dose or anything, it just goes straight to the patient. So the rest of those are your actual interactions. So we got coherent scattering, which, coherent scattering isn't discussed a whole lot because, well, for reasons we'll talk about here in a bit. We've got Compton scattered, and we've got photoelectric effect, and then pair production, photodisintegration are really in the therapy ranges, and they're beyond what we're going to create. So they don't really matter to us, but for a radiation exposure standpoint, and for certainly for radiation therapy, they're important. So coherent scattering, Thomson scattering, classical scattering. What we get, and this is really kind of an over-dramatized appearance to it, what we get with coherent scattering is like narrow angle scattering. So when we talk about scatter radiation, we talk about Compton and the type of scatter that we have to deal with. This is not one of them. The 2 characteristics of Thomson scatter, which is your classical or coherent scattering, is that it's narrow angle and it loses a lot of energy. So what we get is a loss of most of the energy of the X-ray photon, an emission of scattered X-ray photon, but it's going to exist in like a 10 kbp range or lower. So it's going to be very low energy. So most of those are actually going to scatter and then be absorbed inside the patient. So they become, in a lot of cases, a characteristic photon. And if they do penetrate the patient, so let's say we've got a coherent photon that is scattered at the point of exit, they almost parallel transmission, okay? So you're thinking about things like your grids, all right? So what's the purpose for a grid? Clean up scatter radiation, right? What is it designed to transmit most of?
High energy.
Not low energy, but
High energy.
the high energy, the penetrated photons that don't scatter, right? So if these parallel those, then is grid going to do a whole lot to these?
No.
Not really. So you can't really differentiate between a Thomson scattered photon and a transmitted photon except for the energy level. If they're paralleling each other, then they just almost don't matter. They do add some fog because it may be created in one place, may bounce around a little bit and lay down a layer of density that you don't necessarily want, but it's going to be minimal. It'll be minimal because they're going to be low energy, right? Very low energy and very low scatter angles, so they kind of parallel your transmission, and so they're really pretty insignificant. So often called classical or Thomson scattered, is barely scattered, often can't be distinguished from transmission with the exception of that energy level. It only represents a small percentage of the remnant beam. Might contribute a little bit to noise, but it's pretty insignificant. And it may be unaffected by grid use, again, because it's going to parallel your transmission. So because of all that, we just don't focus on coherent scatter all that much. You need to be familiar with the name, and you need to be familiar with the energy levels. You're going to be low energy levels. And you're going to need to be familiar with what it might contribute, but what that may be unaffected by the grid use. But you don't need to spend just a whole lot of time mentally working through coherent scattering. You just need to be vaguely familiar with it. Compton scatter, on the other hand, is a lot different. So with Compton scatter, what we get is wide angle scatter radiation and still got a lot of energy left to it. So Compton scatter, likewise, might scatter multiple times inside of the patient, lose energy every single time, and it may eventually become photoelectric inside of the patient. But if it exits the patient, it still has high enough energy to do some damage to your image. Okay, so these are the ones that are really going to reduce your contrast by laying down that layer of fog. Wide angle scatter radiation with a lot of energy left to you know, put down a layer of density on your image receptor. So it's wide angle scatter, adds no beneficial information to the image. It just creates noise. One photon may create many Compton interactions inside of the patient. Okay, so this is something that, you know, we just don't stress a whole lot. But what's going on inside of the patient is very similar to what's going on inside of the target. Okay, so you make an exposure to the patient, to the patient. Well, let's back up. You make an exposure on the target, and what are the ways we create X-rays? The incoming projectile electron does what?
Loses its energy.
Displaces.
It loses energy in brims, right? So it loses energy, and that energy is emitted in the form of an X-ray photon. But if it hits an electron, it ejects the electron, and you get a characteristic photon created. So what's happening inside of the patient is really the same thing. If we eject an electron from the patient, and let's say that photon still has more energy than the binding energy of that electron, is it going to stop?
No.
No, it continues on. So it may hit another electron, and it might hit another electron, might hit another electron, and so on and so forth, right? But is that a normal condition for that atom to be in, to be ionized?
No.
No, it's not. So you got a free radical, that Compton electrons floating around out there. If it's got a lot of energy, it might hit another atom. So you got an electron that hits another atom. It hits an electron. It's got more energy than the binding energy, of the electron that it hits. So what's it going to do to that electron?
Ejected.
Eject it, right? So you got another free radical. Is that a normal condition for that atom to be in? No. So in the target, when we eject that electron, what happens?
Another photon?
The photon is, or a photon is created, right? Same thing happens inside of the patient, okay? So the patient becomes an X-ray beam as well, right? So one X-ray photon can create a lot of Compton scatter. So now you go, think about tissue types, different types of tissue. You make an X-ray on a thin tissue type with a lot of bone. Okay, you're going to create a lot of scatter radiation?
No.
Probably are, but a lot of the scatter radiation is going to lose a lot of energy every time it makes an exposure. It's going to lose a lot of energy and it's going to absorb inside of the patient without coming out, so you get a lot of high contrast. But you get a patient who's got a lot of soft tissue, you're shooting through a lot of water, a lot of this stuff's going on, right? So you're creating a lot of Compton scatter inside of the patient, loosely bound electrons are just bouncing all over the place. You're creating a lot of Comptons inside of the patient that will exit the patient and do what to your image?
Create fog.
It's a lot of fog, right? So one photon may create a lot of Comptons. The likelihood decreases with increased KVP. As KVP goes up, we tend to say as KVP goes up, what happens to scatter?
Scatter goes up.
Scatter goes up, right? But it's really not true. As KVP goes up, the likelihood of any kind of interaction inside of the patient decreases. But the likelihood that the scatter that you create is going to penetrate through the patient increases. Okay, you see the difference between those two? As you increase KVP, the likelihood that you get penetration increases, the likelihood that you get any kind of interaction decreases, but what is interacted inside of the patient is more likely to penetrate through. you get more remnant beam in all energy types, not only penetration, but also in scatter radiation as well. So the likelihood changes with changing tissue type as atomic number increases. The likelihood decreases. You get more photoelectric interaction, you get more absorption inside of the patient. So as density increases, less likely to penetrate as well. So it's most significant in tissues most resembling water. If you've got a patient with ascites, again, then what you're going to create is a lot of Compton. And again, if you've got a patient who's hypersthenic, you're going to create a lot of Compton interaction inside the patient. So photoelectric, that's where we have all of the energy of, certain percentage of the photons are going to be absorbed inside of the patient. With the photoelectric, we can have an ejection of electron, and we can create a characteristic X-ray photon inside of the patient, just like inside the X-ray tube. The patient becomes an emitter, and you get isotropic emission. There's just no telling which way it's going to go. So likelihood of photoelectrics occurring is dependent on atomic number, and it's affected by KBP. So the higher the atomic number, the more likely we're going to have photoelectric interaction. And it's affected by KBP. The higher the KBP, again, the less interaction we're going to have, the less chance of photoelectric or Compton we're going to have. But again, the Compton that we do have will have higher energy and penetrate through the patient with foggy film. So, photoelectric interaction. All right, so any questions on those?
Yeah, I've got one question about the Compton. Why is it when you increase the atomic numbers, that would be increasing the number of electrons, right?
Right.
In that, why would it decrease the chance of a Compton?
Well, good question. With the increase in atomic number, you get an increase in the size of the nucleus, so the binding of those electrons increases. So again, even with photoelectric, a lot of your photoelectrics start out as they may lose energy
Yeah.
and technically become scatter radiation, but because you got so many of those nuclei so densely,
They're harder to knock out?
yeah, it's harder.
Okay.
They lose energy significantly faster, and eventually, even if they do become Compton initially, they become photoelectric pretty
Yeah.
quickly. That's just density is the availability, yes, but the availability and how tightly they are bound.
Yeah, I was thinking of just more of them, more chance of hitting one.
Mhm.
So, yeah, I was thinking about it wrong.
Yeah.
Okay.
Anything else? Actually, I pulled up just a little too soon. I was thinking that I'll put the pair production photo disintegration all the way at the bottom. So let's just touch on differential absorption real quick, and then we'll watch the video. So differential absorption, differential being difference in order to see contrast, what we have to have is differential absorption. And not only just differential absorption, but we have to limit the scatter radiation with the grids as well. So differential absorption and image production. So higher atomic number, we reference that by Z number, or ZEF, you'll see it referred to sometimes. So photoelectric absorption is greater in absorbers with higher Z numbers, higher atomic numbers, so the more likely you're going to have absorption, even if it starts off as Compton. So as we increase KBP, we increase the numbers. We increase the percentage sharply, or as we increase KBP, what we get is an increased Compton proportionally, much more so than what we get with the change in photoelectrics. So what we get penetrating through the patient, again, is a greater percentage of your Comptons as opposed to what was absorbed inside of the patient. So what we get is greater percentage of penetration through the anatomy that we're interested in seeing. So if we're shooting chest x-ray and we use low KVP, a lot of those photons stop on the ribs. We can see the ribs very, very well because we get a higher absorption rate. But as we increase our KVP, we get penetration through those ribs. Not only do we get penetration, but we also get an increase in scatter radiation. And what we'll wind up with is an image that is more gray, so we lose contrast. So reduce KVP, we increase our contrast, increase KVP, we reduce our contrast. Increase KVP, we get a decrease in differential absorption. We don't see that difference as well. Our contrast goes down, right? As we increase KVP, contrast goes down, differential absorption goes down. As we decrease KVP, differential absorption increases and contrast increases. So increased mass density, again, we're gonna have PE absorption increases and Compton scatter is gonna increase as well. So increased mass density, you go from one type of soft tissue to another type of soft tissue. You go from, let's say, fat to muscle. It's still soft tissue, but it is an increased overall mass density. So your PE increases, but your Compton scatter increases as well. So, chart should be in your, did that come through in your packet? Yeah, not very
A
well.
little bit.
Yeah,
I'm sure if we had the lights on, you could see it, you could see it better.
yeah. I'll leave it up there for a minute so you can kind of draw the arrows if you like.
Is this loaded on your canvas?
No.
Okay.
Now, this will be loaded on the canvas, the PowerPoint.
Okay.
Turn that off. See it out. All right, turn the lights back up a little bit more. What's it saying, resume?